Okay, you said just let me, so I had a pillow on my desk and I took it. Thank you everyone for coming today. I'm not sure what kind of weather you're having, but I'm in rural Pennsylvania and it's been snowing since I got up. On top of those frigid, oh God, it's 16 degrees. It was -3 the other day. So I do understand that DC had some traumatic temperatures also. But we've had some changes, and I guess my disappointment in the number of participants is because I want to make sure that everyone gets this information. Bear with us. We're going to be doing some repeats, that we do have some new staff with us. So, well, we've got new staff, we've got newer surveyors, and you're not new to the survey process, but you may be new to this type of SNP review. So we did add some slides back in that we sort of highlighted last year. And I just want to walk through and make sure that everyone is on the same page. So please bear with me. Don't tune me out because, as I said, there are some things that have changed. Okay? With that in mind.
Can I ask a question, please?
Sure.
Sure. I don't know if other people are having problems, but I cannot open the Skype, nor can I open the files that you sent. And I'm not sure if it's a problem on my end or other people are having the problem too.
I agree. I was able to open the Skype. I'm not seeing anything in particular.
I'm in Skype.
And I was able to open the slides as well.
I opened the slides, but I'm just on the phone.
Okay, then those of you who are on the phone and you can open the slides, please just follow along with us. And I will attempt to identify the slide that we're on so that you can follow along. I'm wondering if the problem, Delia, is that we have internally everyone can see, or is there anyone external who can see the slides on screen?
Yeah,
This
I'm
is
external.
Chris. I can see.
Okay, hi, Chris.
So,
yeah, this is Gene. I can see them.
so for those, I think what's happening is for those who joined after I'd already put up the slides, they may not be able to see it.
That's okay. We can follow along on the slides. That's okay.
Yeah, because everyone received the slides.
Yeah.
And let me ask if we've got someone like myself who cannot see the slides from any way, shape, or form, and I don't know what's going on that I can't, should I still be listening along? What would you recommend?
Listen along, and I'm also recording this, and I'll be able to send out the recording, so you'll be able to view it, and you'll be able to see the slides in the recording as well.
Sandra sent another email with the PowerPoint document. So if you go to that email and just download the PowerPoint onto your computer.
Yeah, I tried that. It's saying the file is too large, believe it or not.
Oh, that's your computer.
Okay, then I would say let's just wait until Delia sends the recording.
Okay, thank you.
So if you want to hear it live, I would say please continue to listen in. If it's too much of an inconvenience, then you can listen to the recording, or you can attempt to come to the next one on February 5th.
Okay, thank you.
Okay, and thanks for letting us know. Okay, we're going to the second slide. And basically, this is just the agenda. I'm going to talk about the objectives of the training. In other words, how we started. Again, some of you may know, but I ask for your patience as we go through for your peers who are just joining us for this first time review. We're going to walk through the MOC elements, a high-level overview, and talk about how they're scored. I'll show you the project timeline. We do have some reminders. And then we'll go through each of the elements. We'll talk about technical assistance during the cure, and basically that is how to, well, that's for the cure. We're going to talk about how to submit So as I said, we have 2 brand new staff members. They are not brand new to the healthcare arena. So please welcome them. They are Linda Uwumurogi and Avni Barucha. And they'll be talking with you today.
Hi there.
All right. As far as the training schedule goes, you know that this is one of 2. However, we will be recording and you will get that information. So I will need you to let me know if you don't get either one, because that presents a problem for you to be able to review the tools. And of course, we will show you the contact information. So slide 3, please. All right, you can go to 4. The objectives of the special needs plans. As you know, the Affordable Care Act came out, and basically these requirements came as a result and in an effort to comply with the requirements of the ACA. Basically, what we're going to do is ensure that SNPs have a robust model of care. And yes, I did read from the screen because I want you to know that that's the purpose for your being here. The approval periods, there's been somewhat of a change, and that change is relevant to C or chronic SNPs only, but there is, and initially there was established a 3-year approval period. We'll talk about what scores collaborate with or with those percentages or the approval years as we go along. Next slide, please. We're on slide 5. And these are the model of care elements. As you know, MOC 1 talks about the target population. We want the plans to describe their specific target population. I don't want to hear about what dual eligible SNPs look like, or C-SNPs or I-SNPs. I want to hear about what, let's say, we'll use our fictitious health plan or SNP plan, and that is we want to see what Smart Health's target population looks like. So as you're looking through, and I'm going to, it's not just me, Linda and Avni are going to talk about what we need you as the surveyor and you as the executive reviewer to do to help us along. And the rationale for that is, for the past couple of years, we've had to QA every one of these submissions so that we can report back to you and let you know what you did right and what you did wrong, or where we can improve. So because I've got new staff, and I'm crying here, because I have new staff, I need you to help us out. I need the ER to review, look at what the surveyor has said, and if it's not right or you don't agree, if you need to have a conversation with us, please do. If not, and you know the answer, then the answer is not right, I need you to let us know in an email back to the team. And let's say you're letting us know that your assignments are complete and we can move them to the next stage. However, this surveyor did not respond correctly here, or I made a minor change here. It's not for judgment. It's for correction. It's for helping us along in the QA process. And I know that was a drawn out explanation, but I think I left off at target population. So I'm going to get back to the slide. Stop laughing at me. MOC 2 talks about care coordination. And we want to see, this is where we want to see their staff, information about their staff. We want to see who's responsible for oversight. We wanted to see an org structure. So please, if that's not in there, surveyors, mark it down. ERs, mark it down. MOC 3 talks about the provider network, and this includes facilities and practitioners. In MOC, oh, let me go back to MOC too, because my staff knows this is a pet peeve with me as well. Under that care coordination, we want to see their training information. I don't want just for initial plans coming through. You may know that, yes, this is an initial, but you can tell if they do not have examples of the slides. You better believe I want to make sure that they have a copy of a detailed description of the table of contents, not just a TOC. I want to see what's in there. I'm looking for Ragu here, people. It's in there. If it's not in there, then neither is their score. Okay, I'm trying to make light. I hope that this doesn't sound too aggressive, but these are some of the areas that we have to go back and change upon QA. So that's why I'm dwelling on that. So we need that for the provider network as well. Are there training slides there? If it's not, is there a description of that? Or each topic that they're trained on? And MOC 4, we want to talk about the quality measurement. This quality measurement is on the plan level and on the results or outcome measures level. So there's two components there that we're going to talk about when we get there. Okay, moving on to slide 6. Here are the scores. As you know, for 85% or above, there's a 3-year approval, and so on and so forth. Okay, for those of you who are not seeing, I'm going to just say 75 to 84 is a 2-year, 70 to 74 is a 1-year, and anything one scoring 69% or below. So anything less than 70%, they have to come back for the cure. As I said, there is a change here for C-SNPs, and I'm getting there, so bear with me. Next slide, please. Here's the timeline. You may be aware that the SNPs are submitting on February 13th. We will have the timeline when we need your reviews back. Adelia always puts that information in the email, assignment email. We want them sent back as batches, as you know, so Avni will talk about that when we get there. What I want you to see is that the plans have a technical assistance call for the cure. And if you want to be on that call, we can send you that information as well. Next slide, please. So here we go. What happened recently that caused a change for the C-SNPs? You may be aware of that, but here we go. We're on slide 9. The Bipartisan Budget Act, also dearly referred to as the BBA 2018, changed some of the reporting requirements for C-SNPs. And believe me, on Tuesday and Thursday of this week, we received an earful. We being CMS and NCQA, on when did we know, what did we know, and how come they were just finding out. So, but, you know, CMS cannot release anything until they are given the okay by their leadership team. So the SNPs were notified via HPMS memo that this is what's happening, and that all SNPs, or C-SNPs, I'm sorry, regardless of their standing. In other words, 2 years ago they could have received a 3-year approval. Last year they could have received a 3-year. They must return back this year. And there are other reporting requirements that down the line will go along with that, but CMS is not talking about that yet. So C-SNPs will have a 1-year approval, and anyone coming back for cure will have that. There are no off-cycle C-SNP submissions allowed for revisions. Those of you who help us with revisions, you will no longer have a C-SNP to review, because they have to come back annually now. There's no need for them to make any revisions or submit anything for revisions, because we're going to see it on the next review anyway. This does not, please put your phone on mute. Thank you. This does not apply to D-SNPs or I-SNPs. And again, I already talked about C-SNPs cannot submit during off-cycle. So, next slide, please. All right, here we are with the reminders. And these are things that we share with the plans. They must address the regulatory language in the specific elements. So you as a surveyor and ER are looking to see that those things are there. Specifically, process details and descriptions must address the who, the what, the where, the how. Again, I mentioned in the staff structure that oversight responsibilities should be in there, and that should be in there. We're also looking for credentials. What types of individuals are there? What are the skill sets required? What are the educational requirements? And we told them that you, as the reviewer, will score the MOC narrative based upon the scoring guidelines. As you know, those guidelines are highlighted in each element where it's applicable. And what I want to bring to your attention is we've seen a trend over the past few years. They went from specifics down to general statements that are supposed to, and I suppose I'm using my air quotes here, are supposed to describe their processes. And what it is it's not specific. It's a general description. This description must be applicable to their or this particular SNP in which they are writing about. So there may be a number of SNPs that hold a common MOC. But if they're changes, they must highlight what the changes are for this target population. And Linda will talk about that when she gets into that those elements and factors. Next slide. Okay, also we asked them to identify any MOCs or that share a common MOC in their matrix document. Again, the description of their target population for that specific area. We told them that the information or documentation they're looking for must be relevant to their particular population in that service area. Not, as Linda will tell you, national statistics.
Okay, Sandra, this is Marie. I see a lot of that, so I'm glad we're going to talk about that.
Okay. Thanks. We said while the regulations really haven't changed and the scoring guidelines haven't changed, what is expected is that this MOC this year will be reviewed as this is the first time we're seeing it. So we're looking closely. And while we are conscious of inter-rater reliability, we are also looking to see that the requirements are addressed, each of the elements and factors are addressed, and you as the surveyor or reviewer may see something that a previous review did not. While we're hoping to combat, as I said, IRR, we're not going to ignore it because we didn't mark it down before. So that's why we're saying these are reviewed as a first-time submission. We're not holding them to a higher standard. Our expectation is that everything will be met. Okay, so what we ask them to do is think of this as an opportunity to go back to your MOC, look at those things that are working and not working. What are you addressing to change it, to make improvements? Again, they should make sure that all of the elements and factors are addressed. And look at their explanations. Does anything need clarification? Okay, this just says that MOCs will be reviewed and scored based upon this review period. And this is not new. We should have taken this out. That you know that the tools will be in IRT because we have transitioned to IRT. Again, the first time that the only people who see this is us as NCQA and you as a surveyor or ER. So meaning that the SNPs themselves do not populate the tool with any information. Next slide, please. And I thought this was next. I'm gonna turn things over to Linda, who's going to introduce herself to you and walk you through a description of the target population. Linda?
Thank you, Sandra, and good afternoon, everyone. My name is Linda Umarogi. I actually am a fairly new accreditation manager with NCQA. I'll be working with Sandra and Delia and Avni very closely on all of our SNP projects throughout the year. A little bit about myself. I have a master's in public health epidemiology. Over the last several years prior to NCQA, I was working in clinical operations as well as quality management at a health plan in several roles. And it really did allow me to be involved in the preparation of annual reviews and delegation oversight. So I'm sort of seeing things from a new perspective in this new role. And I really do look forward to working with all of you, and I hope that we have a successful year ahead of us. So for today, I'll be covering MOC 1, elements A and B, and then later I'll also talk about MOC 3. First, we'll get into MOC 1. It's the description of the SNP population. As I review these elements, I'm going to briefly highlight the factors and provide some example of responses that you might come across. And then towards the end of the session, there will be an opportunity for you to ask any questions. Next slide, please. So the first thing that Sandra and we wanted to note is our do's and don'ts. So we've already spoken to the SNPs during their separate training session, and we did emphasize that these are really important things that they need to take heed of, and we feel like it's as equally important to surveyors as well. So it's going to be essential for you to always refer back to your matrix, the regulations, and the scoring guidelines when you're conducting your review. And it's really going to help you stay in line with what we require. We've emphasized to the plans that they really do need to provide details about their SNP population. So a review of their documentation should answer the question, who are they servicing? We want them to speak about the, to the age, the linguistics, the gender, different unique characteristics within their population. Tell us what their needs are and the available services that they have, which are going to address those needs. And we've asked SNPs not to add extra documents. Everything must be in the narrative, but if you come across some embedded documents, which sometimes in the short time that I've been doing this, I have seen, please open those, because sometimes they have appendices, they have different links that actually might help you when you're going through the review, and you'll want to note that and indicate that in the scores as well.
Linda, this is Marie. One of the other things with that is I've seen embedded documents PDF'd, so they're unable to be opened. So hopefully that was addressed in the training.
Yes.
Yes, we did.
I'm sorry, Linda.
Okay.
If there are embedded links, we have asked that before they hit that submit button, they go back and check that all of the links are working and we can open those documents. So it's okay to have links, they just need to be functioning. And Linda, I do want to add one thing here, if you don't mind. If you are missing a document, somehow we do, during our quality check, we look for the matrix and the MOC. Those are the only two documents that we're downloading. If somehow we miss it and you open that document and it's not there, please let us know by email right away, because that constitutes a no review. You must have those to go forward with the review. Thanks, Linda.
No problem. And we've also asked that SNPs not to forget the detail that we need when it comes to member tracking and verification, and then the overall process for preventing disenrollment. This has been an issue in the past. Another thing that we noted to them was that they should not rely on those national statistics, especially if there's no other information provided about the plan's target population within the geographic service area. And I will emphasize that on the next slide. So we can go
do we have to wait to ask questions?
No,
Because,
please.
okay, thank you. Only because I finally got it working. So this is Carol. So I'm looking at the slides. I don't recall seeing in anything about talking about preventing loss of membership. I do recall, plenty about tracking verification, but this preventing loss of membership, is it actually in the matrix, the regulations, or the scoring guidelines?
I'll take that, Linda.
Okay.
Sure. So yes, it is. In other words, the purpose for this is determining membership, tracking membership, and verification of membership. So that falls under what we're looking for. The onus is on the SNP to prevent loss of membership. So that's why it's in there. That's why we're doing all of that, to prevent that. So the plan must actually show what steps they take to become informed themselves on someone potentially losing their membership. Are they reaching out to those members? And if they reach out to those members and they don't respond, or for whatever reason, then they've done their due diligence. But HHS just wants to know that they are doing everything they can to maintain consistency in Benny membership. Does that answer your question, Carol?
Yes, thank you. Thank you.
This is Deborah. I have a question about additional documents, because I just need clarification, because if they're not allowed to submit additional documents, how is embedding a document okay? I mean, because whatever they want to submit extra, instead of doing an extra, they're going to embed it, which can make an already voluminous document humongous.
We have addressed that. Someone asked specifically, what size are these documents? And we say an average, even a good one, may be scored 100%, will have 150 to 200 pages. I have seen them in less. There may be not as much on certain things, but it's enough to meet the requirement. So it's not that it's extra. Perhaps it's a link, or the embedded is to the appendix at the end of the document. So we're saying don't attach extra documents, but perhaps the link is put there where the elements should be addressed, where there should be verbiage that will, if you click on that link, will take you to that appendix in where that information lives.
So my question is, why don't they just take whatever text is in that embedded document and put it directly into the MOC? I mean, why? Because basically putting links in is a workaround to not being allowed to add extra documents. That is the ideal way to add extra without actually adding extra. So it's a workaround. It skirts the rule.
Well, Deborah, it really doesn't, because we've seen these links. The problem that we have with the links is that sometimes they don't work. But the extra information, or the information that's written out, perhaps someone else was working on it, and rather than put it where it belongs in the document so that it doesn't, propose an error or something, they put it in an appendix at the end. So we have always said, whatever information you're submitting, it must be in that MOC document. In other words, what we're saying about extra documents is often you'll see the HRA uploaded in the wrong place. CMS does ask them to send it, but not with the MOC in the matrix. There may be other QI documents in that section. We're just letting plans know that we are not downloading anything with the exception of the MOC and the matrix.
Okay. All right.
Okay. Go ahead, Linda, please.
Okay, we can go to the next slide. It's actually emphasis on the national statistics. So historically, we've noticed that plans do like to use national stats when they're generalizing their population, and it is useful in some ways. Sometimes they have to describe a chronic disease or comorbidities, but we would stress to them that the overall description has to speak about the specific SNP for their service area in order to meet that intent. So as you're reviewing this section, you want to keep in mind that the population information is going to vary by state, county, city. So for instance, if they're saying something like the CDC reports that more than 11 million people have been diagnosed with COPD, and there's no additional language specific to their target population, that standalone statement is not going to meet the requirement. There has to be some sort of correlation between the broader information they're providing and then their specific SNP population.
Linda, this is Marie Hirenko. Something that I found troubling is the bigger conglomerates, if you will, that have several states and areas that, in my opinion, are drastically different in, be it rural, urban, city, and I don't know, I don't see them handled particularly well. And I don't know if you were seeing that as well on your audits. But I think the bigger plans who tend to put several states under one H contract, for me, is troubling. And I don't know if you spoke to that during training or if anyone else has had that situation.
I don't think we spoke directly to the multi-state submissions. However, you as a reviewer, and this is why this is in here several times or several different slides, and the emphasis is being placed on it. We know that and I'm not calling anyone out in particular, however, let's just say your Kaisers and your Uniteds have populations they may be multi-state. So the expectation is that when they are describing their target population, that they take into consideration, that this is for our Indiana population, these statistics or this response. This is our description of our population in Florida, our population in Texas. Maybe that's too spread out, but you get the idea. So yes, unfortunately, that does make for a larger document, and that would be the exception to that 150, 200 pages. But I have to tell you that I have seen, let's say, certain plans, large or corporate organizations like that do describe multi-states that have this information spelled out via tables: Texas, Arkansas, Pennsylvania. Again, that's a widespread, and it may not happen. They will usually lump those states, those surrounding areas, together in one. Does that answer your question?
I just want to be sure that when I'm looking at that, I expect them to be addressed individually.
Yes.
Okay.
With that MOC, yes, that's possible.
Okay. Because they're different populations to me. Okay, thank you.
Yes. If it says this MOC is for Maryland, D.C., and Virginia, you better believe when I'm QAing, I'm looking for responses to all of the elements and factors for all three of those states. Okay?
Thank you. That's good. Thank you.
And if you are an ER, if the surveyor didn't do it, I want you to go back and mark it down, and I do want you to let us know. I've got 3 staff members now where we can go back and provide you with the feedback that you need to make sure it doesn't happen again. And again, it's for learning purposes. So if my tone is such where I'm criticizing, I don't mean to sound that way. I just need for you to help us out so that we don't have to look at 200 or 300 different ones when we've got surveyors looking at it and ERs looking at it. So help me out. Thanks.
Okay, we can go to the next slide unless there's a question. Okay, so this is actually an example, and all of these examples that we're going to talk about, they're obviously not all inclusive, just meant to be for reference purposes. So if we look at or reflect on MOC 1A, Factor 1, this is the requirement of the description of how staff will determine, verify, and track eligibility. One of the first things that we've encouraged you to look for is it needs to be documented in their documents. They need to show that these individuals with special needs are being tracked and how they're keeping track of the population. So I know Sandra will probably emphasize this. If you don't find this information, you do need to score them down. In this particular example, we're talking about the Smart Health Plan. They've indicated that they have enrollment applications that capture their member info. Their analysts verify information with the Medicaid state system. They've also discussed how frequently this occurs. And for them, I believe it's on a monthly basis with the state agency. They talk about the time to completion before disenrollment, and the overall eligibility process is very well defined. There is no real specific guideline on the length of the documentation. The length of that will be determined by the SNP's procedures, and they'll choose how they want to present that to us. We can go to the next slide. So here's another example of how plans can identify and describe both the medical and health conditions impacting their SNP beneficiaries. And we're looking at MOC 1, Element A, Factor 3. In this example, they are discussing a C-SNP population. So you'll see that the primary chronic condition is noted as diabetes mellitus. They've also noted different comorbidities, as well as included information about their beneficiaries' current health status and external factors that are probably impacting that status. So it's up to the plans to draw that correlation between what they're presenting as their target population and all of the other elements within the MOC. We can go to the next slide, please. So now I'd like to review MOC 1, Element B. The intent behind this element is for plans to identify their most vulnerable beneficiaries. In other words, sometimes called the sickest of the sick. And this is a subset of their general SNP populations. And we find that plans do struggle to convey the distinction here. How they choose to classify this is really up to them. It could be based on the number of hospital readmissions or even a certain diagnosis, which will require them to have specialized services for their needs. So we don't really seek to know individual members, but instead we're looking at population level perspective. Next slide, please. So here we're considering MOC 1B, and as I mentioned before, plans do struggle with distinguishing their most vulnerable beneficiaries from their overall SNP population. We did talk about some do's and don'ts with them. What we do want to see, we want to see that plans are characterizing this group. So highlighting the differences between them and the general population, as well as when you're reviewing, you're looking for the different resources and the services that exceed what is available to the general SNP population. What we don't want is the exact opposite of that. We don't want them to generalize. They're supposed to really be highlighting the specialized resources. Next slide, please. Thank you. So in this next example, we're taking a closer look at Factor 2, and we're examining the organization and how they're identifying its vulnerable members within their SNP. So the Smart Health Plan, they've mentioned that their vulnerable members have both multiple chronic and complex behavioral health conditions in their description. They believe that some of these issues have impacted the number of readmissions into the hospitals. And on top of that, the population has been experiencing some issues that kind of limit their access to medical services. So they outlined the unique characteristics that included caregiver issues, abuse, neglect, literacy levels, other important factors which really help to paint that 360 view for us or paint a picture for us. We want to see that they have some type of special services and programs that are tailored to address the vulnerabilities in the subset. So the key word here is difference. At the end of your review of this section, what we want you to be able to do, hypothetically, is create a list of differences between the general population and that most vulnerable beneficiary subset.
So, Linda, this is Marie again. It seems to me like the deciding factor would be more of the social determinants that influence, because the conditions could be similar, but that some of these social determinants might play into. Am I reading what you're saying correctly?
I would say that the plans are going to be the ones to determine how they're separating the subset out. So it could be based off of, let's say they have high readmission or high use of a certain service. They're going to be the ones telling us that information. And then, Sandra, if please let me know.
I was going to say, the short answer is yes.
Yes. Okay. I was going on tangent.
That would be.
Okay. Yeah.
That could be, but what Linda said.
Not all inclusive, but yeah, because I do see what you're saying where they're really not distinguishing. So I just want to make sure my charge is very clear on this. So thank you.
Yep. Linda's just saying we're relying on them to tell us, yes, this is what we use. Okay, Linda?
Okay, we can go to the next slide, please. So this is the last example. We're looking at element B, factor 4. The requirement is asking for identification and a description of the established relationships with partners in the community. So what Smart Health has done, they've identified these partnerships and resources, and basically they're talking about some of the local community resources. So they've named the food banks, soup kitchens, cell phone program, crisis relief center, but you'll notice that they've provided a table which really identifies these resources by name within the service area. You're going to probably see different formats. They'll definitely vary there, but plans are going to choose how they want to represent this information as long as it's there as what we're looking for. Next slide, please. So in conclusion, I'll wrap up this section just doing a quick overview of what we just discussed. We looked at element A, so this is where the plans are asked to identify and define their general SNP population. And then the MOC builds upon that definition in element B. We're looking deeper into this population and we're requiring them to identify the most vulnerable beneficiaries within the SNP and how the plan intends on addressing their needs. And we also stress that if they're going to use those national stats, they need to correlate it to their target population within the service area. So as you're reviewing, these are some of the things that you'd want to look for. At this time, I'd like to open up the floor to any questions that you might have on MOC 1, elements A and B. And we can go back if we need to.
Okay, before we do that, and I don't know how much time, if people are going to be listening to the whole thing. So I want to take a moment, and if you did not already let Delia know that you're in attendance, if you will, one by one, give her your name. Thank you.
Hi, Linda, it's Maria again. I'm sorry to be such a pest, but when we're talking about the community resources, we want to see the specific community resources that they're using, not necessarily that what area they're in, that's kind of extra, but what their specific community resources are, rather than a general we use, we outreach and we use.
Correct.
That's,
yes.
Okay, thank you.
Okay, one more time. Did everyone give your name to Delia at the beginning?
No, I'll say now.
Hi, Delia. It's Chris Bradley. I don't think I did at the beginning.
Hi, Delia. This is Angie Beatty. I don't think I said so either.
Thank you, guys. I was able to get some off of the participants as well, but go ahead. Keep going.
Hi, Carol Moretti.
Thanks, Carol.
Thank you.
Anita
Celia
McCreevy.
Marie Harenko. I just want to make sure you heard me.
Yes, Marie and Anita McCreevy. Perfect. Thank you.
Angela Bryce.
Oh, I got Angela next.
Grace
Ozzy Ahmed.
Oh, thanks, Ozzy. Thanks, Grace. Okay.
Diana Walterek.
Thanks, Diana.
Tina Morton.
Thanks, Tina.
Okay, thank you. Are there any questions regarding SNP MOC 1?
Sandra, I didn't get, this is Chetney Arrington.
Oh, hi, Chutney.
Thanks, Chutney.
Hello.
Okay. All right. Well, if you think of a question, hold it, and we will get back to you. I'm going to talk with you about MOC 2, and we can continue in this pattern. If I see that we are lagging behind a little bit, I will hold questions until the end, and we'll get to them then. Okay. Next slide, please. For those of you who just have slides, we are on slide 23. So MOC 2A, care coordination. I think I gave you a high-level overview initially. We're looking for SNP staff structure, and again, there are two components to this. We're looking for the clinical as well as the administrative. As Linda said before, we started with or let the plans know what they should do and what they should not do. I've said clinical and admin roles. Everybody should probably know that my pet peeve is detailing the training information, and as well as for the staff structure and detailing the educational components of the training for overall. Okay, there's their staff and their provider staff. What happens when the staff the contracted and non-contracted, do not participate in the training? And did they provide their org chart? And I think as I went through, I went in talking about what they should do. I also mentioned what not to forget. So I'm going to move on to the next slide. And here again, I know you all know what an org chart looks like. Sometimes there will be more than one. There may be one for their QI structure. There may be one for overall organization without the drill down that you see here. So there could be one, that's fine, but they have to have at least one. Next slide, please. So these are our cute little handouts. Linda already talked to you about some of them. I'm not going to read verbatim what's on this slide. I do want you to know that in describing how they conduct their trainings, initial and annual, that they should give you a process. These handouts are not all-inclusive, and we have made that known to the plans, just in case they get a hold of these slides and they say, well, this is one that you showed us, and this is what we copied it. But yeah, but it doesn't include responses to address all of the factors, and that's what we want you to see. But sometimes reviewers and plans have said, give us an idea of an example of what you're looking for. And as you see in red highlighted, again, my pet peeve, please don't just hand me a table of content, because that infuriates me. Okay, enough on that. Next slide. So we had some questions about the HRAT, or Health Risk Assessment Tool, yesterday. So I let them know that we don't necessarily have to see, when in reviewing this MOC 2B, what we're looking for at NCQA and what you're looking for is that they have addressed the uses and collection, and what happens if they can't reach a beneficiary. So those are the things that we're looking at from an evaluation standpoint. They must have the process. Again, the MOC narrative is all about the process. And I guess it stands to reason that it should be clearly written. What happens if they can't reach out to a member? The regulations say that all beneficiaries must have an HRA. From some of the information that they see, wherever they get the information or collect it from, they can start some kind of review where that feeds into, you must have an individual care plan, and you must have a interdisciplinary care team. And we'll talk about those in subsequent slides. Next slide, please. So we talked about the HRAT already, but our fictitious plan, Smart Health, also talks about getting that information and using it in the ICP, and how this information is disseminated. So when you get a chance, just kind of read through these handouts, as we call them. Next slide, please. Basically, just like the HRAT, we're looking for the same kind of information, but as needed for the ICP or individualized care plan. It must describe the process, that is, must describe the essential elements of an ICP. How they select staff that review for this, that is the providers. Who is in charge of monitoring and upkeep of the ICP?
Is there a fork or anything? Knife? Spoon?
Hello?
You want to travel?
Thank you. Okay. How modifications and updates occur. So what we ask them to not forget is, remember that the regulatory language is there, and they really need to address what happens if members are not accessible. Okay, and you can see that it says here things that they should make sure are in the process, and that is, or includes, beneficiary and caregiver. How does the beneficiary take play in this ICP prep? Next slide, please. Okay, another handout. Basically just describe the MOC process and the staff responsible. And it also includes how it's selected and their professional requirements and credentials. And don't forget the beneficiary and caregiver. Next slide, please. The ICT, or interdisciplinary care team. Again, this is one that has regulatory language saying that every beneficiary must have an ICT. And the plan's bulk. But, you know, again, this is a requirement. They need to know that as much as they can prevent it, that this beneficiary doesn't fall between the cracks. We've already said that these special needs plans deal with specially vulnerable members. Again, there's that differentiation between the general population, which is different than your overall Medicare Advantage population, as well as the most vulnerable in there. So just mere mention that they are all special and they're all vulnerable to a point. We need to make sure that we're doing everything possible to ensure continuity of care. So that's what this is all about. There must be a plan. The plan must be reviewed by the ICT. Basically, that's what we're saying here. How do they communicate this plan? Who's responsible for coordinating these activities? Okay, next slide, please. How do they determine the composition? It all falls back to the foundation of the MOC elements, and that is the target population. So once they've determined their target population, they must look at the needs of the population and understand whether or not they have the infrastructure. And in this case, I'm using infrastructure not as just a building, but I'm also using it as the provider network. Do they have the specialties to address any issues that the beneficiaries must have? Training, teaching, coaching, the facilities necessary to do the testing and follow-up care. So all of these things we're looking at in to address this population and their ICT membership. Next slide, please. Improving the health status of the beneficiary. So that's the end result or the objective of the ICT moving. As far as I'm concerned, what else do we need to say about this? It's looking at the data, collaborating with the team. Do they need to go outside of the team for additional expertise or skill set? Managing all aspects of the member's care. The medical, the social, any behavior. And again, remembering that the center of this is the beneficiary and the caregiver. What does the beneficiary need to do in order to be participating in their care as well as the planning? Next slide, please. Care transitions. I guess before I even start with this, we spoke about this yesterday during the plan trainings. Basically, does the beneficiary and any caregivers know the pre, the post, and the during the transition? When do they become alert to the fact that there's going to be a transition of care? Who do they contact? How will my care plan and my present treatment plan be transferred to wherever I'm going? Do I have the information that I need to be able to speak to anyone who questions me being the beneficiary during these talks? Do I need to do anything, let's say, as far as self-management when, let's say, I'm going home? That's still a transition of care. And I know I'm preaching to the choir, but you as the surveyor and the ER, these are the things that you're looking for. But most important, outside of the beneficiary and caregiver themselves, is the point of contact during these transitions. Okay? Next slide, please. And this is another handout or example. Basically, what Smart Health has done is name those important staff who are integral to this process. Yesterday, I pointed out that in this case for Smart Health, it's a nurse. The case manager can be an LPN or an RN. It can also be a coach or licensed social worker. And this is what they've demonstrated. They've also provided that they have specialists or analysts who assist in this process. So that's what you're looking for when they talk about who's responsible for. This could be before, during, or after, anywhere in this transition. Next slide, please. And this is another handout. Basically, this is just an explanation or part of an explanation for how the beneficiary or caregiver has access to their personal health information and how they can, it's communicated to providers during the transition. Next slide, please. Factor 6 example or handout. the point of contact. So I just went into a whole spiel about this one, but basically this just shows what kind of information they shared to address that. Okay, because we have a lot more to go. I want to make sure that we have a chance to get to that. So are there any questions on what I presented here? Okay. I don't doubt that you all know as much as I know. I know that you're dealing with plans or SNPs in your career or work life. So if there is something that comes up, you have our information. You know how to reach out to us. So with hearing no questions at this time, I'm going to pass the baton back to Linda, who's going to talk to you about MOC3 or the provider network. Linda?
Thanks, Sandra. So yeah, I'm going to talk about MOC3, elements A, B, and C, and it all refers to the provider network. We can go to the next slide. So we really stress to the SNPs the importance of clearly defining their target population. The intent behind this particular element is for the SNPs to answer the question, who serves their target population? So we're expecting them to provide insight into the provider network that's involved in the management of the SNP beneficiaries. And this actually can include facilities where the members receive care, as well as contracted providers that see their members regularly. We really need to know that their provider network directly addresses the issues of their SNP population. So we want to be able to identify those PCPs that are collaborating with the interdisciplinary care team and how the individualized care plan is updated on a regular basis. We find that plans sometimes forget to include how oversight occurs within the provider network. We're looking for them to detail this process. We've asked them not to forget to include their out-of-network providers as well. We want them to tell us the who, what, when, and how oversight occurs and how it's managed. Next slide.
Oh, can I ask a question about this? So if you go back, yeah, thank you. The go back one slide.
Yeah.
So they're supposed to provide they're supposed to include a provider directory, or just that? Yeah, let me stop there. Is that what you want?
Not the provider directory. I think that would be really long.
Yes.
So if please make sure that I'm saying this correctly, but I'm assuming we're just asking for the oversight process.
So that's correct, and we don't need to say any more. We're definitely, that would be cumbersome. We are looking for processes. Remember how that they must state that they're updated and their process for doing so.
Okay, thank you.
No problem. We can go to the next slide. Thank you. So we're now looking at MOC 3B, which is the requirement for the SNP provider network to utilize the evidence-based care and services. So they'll need to thoroughly describe how their providers are using those clinical practice guidelines and care transition protocols. We ask that they remember to include any challenges regarding this, but also to identify who can make those modifications and determine the appropriateness as well. Next slide, please. MOC 3C is the provider network training on the model of care. And we require that initial training for providers just joining the network happens, but we also want to see a process in place that allows them to maybe circle back for the training materials when it's necessary. So if there are challenges for providers when it comes to trainings, SNPs need to identify those difficulties, and they have to discuss any incentives or best practices offered to address those issues. So if they have, on-site trainings and providers are not able to make it, do they also offer an alternative online option as well. And we've emphasized that the MOC training should be offered to out-of-network providers. So we're actually expecting to see evidence of the trainings, maybe attestations, screenshots, copies of the PowerPoint slides, different materials, and also a description of the topics that are discussed, especially for the initials. Next slide, please. So now I'd like to review a sample response to element A, factor 1. So this factor requires a description of the specialized network. In this case, we're looking at the chronic condition SNP. Smart Health, they are basically describing their plan. They have specialists who are endocrinologists, cardiologists, mental health specialists, orthopedic surgeons, and they're all clinically relevant providers that service their type of membership. They also make mention of the facilities that their members can receive care. So they talk about a dialysis center as well as a rehabilitation facility. Again, these are just examples in terms of the list of providers and applicable facilities. But you actually may come across plans that like to include providers that are considered ad hoc and they're only used under special circumstances. And so when that happens, you want to be sure that the MOC describes the procedures for those instances as well. Next slide, please. Thank you. So we want to highlight the importance of providing the best care for the SNP needs, obviously. More than likely, this is going to involve the collaboration between the member and their providers. And as the healthcare, as you're probably noticing, is moving towards a more person-centered approach to care. So the idea of that interdisciplinary care team is essential in servicing members with special needs. And in this example, the Smart Health Plan, they're describing their ICT. The member is at the center. You have the PCP or the care manager acting as that clinical driver for all of the care the member receives. And the care manager connects the member to the different needed services. They might be setting appointments or coordinating those services for them. So the takeaway from here is that the MOC needs to thoroughly explain how the providers in the SNP network communicate with each other. How is that communication updated regularly? And how it's incorporated back into the individualized care plan. So you want to keep that in mind when you're doing your review. Next slide, please. This slide is another example we're looking at for factor 2, element B. This factor is requesting details on how certain CPGs are going to be utilized based on the needs of the member. So there are going to be instances where a certain CPG is just not appropriate for the beneficiaries, especially those with complex healthcare needs. In that case, you're going to look for plans to identify those challenges, and you want to look for a protocol as to why those guidelines may not be appropriate and who makes those decisions to modify or ignore them. Next slide, please. So this example reviews the documentation for factor 4, and we're looking for them to describe the use of the CTPs, which is basically assisting for, the smooth transition of members from one setting to another. So the MOC needs to address any challenges that are faced, as well as how the SNPs oversee that network. Providers are basically following those required protocols. So as a surveyor, you want to remember that plans need to show how they're maintaining that continuity of care before, during, and after. Next slide, please. So this actually concludes my review of MOC 3 for the provider network section. I'd like to open the floor back up for any questions that you might have on anything that I've discussed so far.
Hi, this is Marie.
Hi.
When we're talking about, I'm going back to that, and maybe Dr. White can give me some feedback here as well, but when we're talking about the care and the clinical guidelines, which are just that, a guideline, so not every person is going to specifically fit to that. and we're talking about who makes the decision not to. I mean, it's clear to me that within the parameters of a physician's judgment that, that is something that would take place. So when we're talking about they need to identify who, then we're not making a judgment call as to the response. I guess I just need to talk about that for a minute. Because, generally speaking, if a guideline doesn't fit, you don't go back to a national association and, try to change a guideline, but you use your clinical judgment to, administer the care as deemed appropriate. So I guess I just want a little more concrete on those kind of situations where someone might say, because I do see that, they said they would, either take this back to, committee, or they would use the physician's judgment.
Okay, Marie, we're talking high level here from a plan operations standpoint. There are certain things that the plan leadership would have stated are within the physician's individual purview. There are those things that do stand out and must be brought. Let's say it's so drastic that they name, and that's what the MOC is all about. We're looking for the plans to tell us what situations that they would allow, or the process, what is their process for dealing with those things that don't fall within that little box per se. So what situations fall there? How do they deal with it? And or I'm sorry, I just keep going back to what is their process for dealing with situations that fall outside of the norm. And that's what we're looking for them to tell us. Not necessarily what are they, but overall, in general, how do they deal with it?
Okay, understood. Thank you.
Mm-hmm. Any other questions on this element? No? We're getting there, folks. Thank you for your patience so far. We're going to be just wrapping this up. We're going through MOC 4, and then Avni is going to introduce herself and tell you what kind of things do I need to know as the surveyor when I'm doing my review. Okay? Next slide, please. So move on to the next slide, MOC 4, quality performance. Remember I said that there were two components here. So right now we're going to talk about the overall plan performance. We asked the do's of the SNPs, and as you can see, let me start with the don't. Don't forget their goals and benchmarks. Within these elements, there are there's information. While we're not looking for actual documentation of their analysis and all of that, we are looking for them to say, these are our goals, these are the time frames, this is what we use to assess against. So don't forget to look for those. As far as what we did ask them to do, we asked them to include, how do you collect this data? Where does it come from? What are you measuring? Who's the key personnel involved? What staff members? Who oversees it? What are your reporting requirements? What happens when goals are not met? When do you perform remeasurement? Okay. And while I did not go through each factor for 4A, these are the high level things that we're looking for. This is what you're looking at as you review. Next slide, please. Factor 2, the Smart Health has looked at their data sources and outcome measures and described that for us. What's important is that little clock right in the middle, and while it's not a time thing like 2 o'clock, a meeting date, we are looking for the time frame for their analysis. and and the process, what happens, how they collect it, who looks at it, all of those things. So the time frame for the measurements, etc. Don't forget the data sources, how they collect it, how they analyze it, how they evaluate it, and most importantly, what's reported to whom. Next slide, please. And basically same thing, just addressing factor 3. Smart Health is telling us that they have a contracted vendor who conducts the collection of this data. And again, just what's involved in the process. Next slide, please. So for 4B, and this is where they may address the actual measurements and who's responsible, who tracks the information, how is it used to assess the overall progress of the QI program. Also, we're looking at how they determine that their goals were met and what happens if the goals are not met. And as far as the don'ts, again, basically we're looking for the information that talks about the outcome. So we ask them not to forget. And how does it correlate back to their target population that they talked about in MOC 1A and B. Next slide, please. So for B, the difference between A and B, as I said before, A is talking about overall plan performance. B is looking at their goals for assessing whether or not they met where they want to be for the outcomes, for member outcomes, overall member outcome. Again, plan performance, outcome results. Next slide, please. And I'm going to go right to the red on the right-hand side of the screen is in determining whether their goals are met. Did they describe their process for ensuring that the goals were met? And the description basically will, in the narrative, you're looking for an explanation that details how that occurs. Next slide, please. If they didn't meet their goals, this handout just talks about the description for addressing whether their goals were met or not. And if it fell outside of those that time frame, the rationale for not achieving the goal. In other words, it's the analysis that comes afterwards. And basically, that analysis is described in a process. So we're not actually looking for the analysis per se, but we're looking for how they deal with it. Next slide, please. Patient experience. In a nutshell, we're looking for the tool that they use for their satisfaction surveys. How do they get the results? How do they incorporate those results into an overall improvement plan? And as far as the don't, like this, looking at the survey tool, we're not interested in just those people who come through for complaints. We're looking for, are they looking at all the means necessary to gather feedback, to look at for areas of improvement? Okay. Next slide, please. Again, these handouts are just details of the description of the process. Basically, what they're addressing here is how they integrated their results into the overall performance plan. Next slide, please. Again, a description of how they address the issues. Well, what is the involvement of the QI improvements staff? What is the process, the steps taken to look at the data? And how's the data collected and reported? Next slide, please. 4D, we're getting there. We're looking at an evaluation of the ongoing. So this is not, the takeaway for this slide is not how are we doing, how do we do for each one of those components, but it's a year-over-year experience. How are they incorporating their lessons learned into the process improvement? Who needs to know? And how is it documented? Where is it kept? Okay, next slide, please. This is just a list of, and there's a lot on this slide. It's so busy. I almost hate to look at it, but there was so much information here. Again, people ask for examples, but what they've done is incorporated an explanation of the process as well as their stakeholders. So we wanted you to see that. What information is used, how they use it. So this is just an excerpt from an actual report. Again, it's not all inclusive. Next slide, please. So last one for 4. How is the information disseminated? As you saw in that last report, don't exclude the stakeholders. Let us know, internal, external. Is it a reporting agency, a regulatory body? Okay, and describing the process for this kind of disclosure and any other reports that come about, maybe an ad hoc report. How is that information sent out? Who is it sent to? So all of that should be in that written narrative. Next slide, please. And again, it's just an example of what I just said. Internal, their leadership, naturally they have to see it. How often, the time frame for these reviews and reports. And as you see here, the regulatory bodies. Again, these are not all inclusive, but this particular SNP, this is who they sent their information to. So next slide, please. Another example of how it's written, what it looks like in the narrative. And don't forget, who's responsible for overseeing and the accuracy of these reports. Next slide, please. And here we are. Any questions on MOC 4? That's me sitting there waiting for your questions.
Sandra, this is Jean. Going back to 4A, when they're writing about their overarching quality plan, you want to really see how the model of care is going to be incorporated into their overarching quality plan, not really their quality plan, but it needs to be related to the SNP model of care. Is that correct?
Wait a minute. You had me with a prepared answer until you said that last bit. So give me that again.
So in 4A, we want to see a description of their overarching quality program within the health plan, but it also needs to incorporate how the model of the SNP model of care is going to be fed into their quality plan.
Well, it's going to be inclusive in their MOC narrative. So yes, we're looking at the overall QI performance plan and the processes that occur.
And the process is to include the SNP model of care.
In other words, how the QI program affects the overall model of care. Yes.
Okay, right, gotcha. Okay, because we don't want to see where they don't mention anything about the SNP model of care, because then it sounds like they're just writing about their health plan.
Right.
Okay, thank you.
Okay, Jean. Next question. Nothing. We'll give you time to think while Avni goes over her presentation. So how do you do what you do? Avni?
Thank you, Sandra. Good afternoon, everyone. My name is Avni Barucha, and I'm an accreditation manager. I've been with NCQA for about 2 years now, and I'm looking forward to working with all of you on the SNP MOC project this year. So for today, I'll be going over some important information about conducting the reviews. Next slide, please. So here are some important things to know about Surveyor assignments and Surveyor resources. The Surveyor assignments are pre-assigned and are based off of your conflicts of interest, the number of submissions received, as well as if you are considered full-time or part-time based on the availability that you provided to us earlier. Although there usually aren't many plans that come back for the cure, we do try to give the cure assignments to the same person who reviewed it during the initial review, but again, that just depends on availability. We are going to be providing a mock peer evaluation that the executive reviewers will fill out about the surveyors based on their initial reviews. Since the executive reviewers are a bit more seasoned, we are looking to them for their feedback. And as far as resources, once we get them up and running, the resources will be made available in several locations, including online in the IRT in the Surveyor resource guide. The only thing that you will not have access to online or in the Survey resource guide are the expense forms, which we will provide by email with the assignments that we will be sending out, which will come from the SNP approval email address. Next slide, please. So now moving on to IRT. We know that many of you are already familiar with the IRT system, but we will be providing instructions as tip sheets. Once you are ready to start your review in the IRT, you must retrieve both the MOC and the matrix from the document library, and you will be scoring the tool per the MOC guidelines. We just wanted to note that we do not score down an organization during the cure, we only score up. If something was missed and was found during the cure, these will still remain as met or whatever it was originally scored as. Please also make sure to pay attention to corporate relationships. If there is a similar or like MOC, we want to make sure reviewers are scoring consistently. For this reason, we do provide surveyors and executive reviewers with each other's contact information. If you do not want your contact information given out, please just let us know as soon as possible. Also, when using the IRT, please remember to click Save after each element and after each change that you make. You also want to make sure to review the score summary and make sure that the scores that you've assigned under each factor and element are the ones that you are seeing under the score summary. In the IRT, you will also be able to run a validation. There are certain characters that we consider as not acceptable since HPMS does not accept these characters, so that validation tool will be helpful to pick up on those characters as well. Also, surveyors and executive reviewers will have access to the timeline in the IRT in order to move the tool forward as reviews are completed, and that will set off an automatic notification to us at NCQA. So please address questions to Sandra or Linda as soon as possible in order to make the process smooth. And if you have any issues completing your assignments, please notify the SNP approval mailbox. Next slide, please.
And before you go on, Avni, I do want to mention or just elaborate on one thing that you talked about, and that was the score. So we did notice last year that there were some blank circles. Please make sure that it's either scored not met or that the answer is missing or the answer is wrong, whatever you need to do. Make sure there are no empty circles that are not highlighted. Okay, thanks, Avni.
Oh, I'm sorry, real quick, this is Delia, and this is actually speaking on the timeline. And most of you are surveyors, but for those that are ERs, we had some confusion last year. It was our first year with IRT, but when the ERs are complete, you don't want to hit initial review complete box. You just want to move the timeline to the QA. And it's the same for surveyors. When you guys are done, you just want to move the timeline to QA. Or not to QA, to the executive review. And I'll talk to you guys about that, the SNP team. Again, it was just something I thought about from last year that we seemed to, the timeline was moved too far along. So, and I think there's a document where we have those instructions that we might need to update. We just didn't know about it until we started working in it, but it is something I remember now. So thank you so much. Go ahead, Effie, sorry.
Thanks, Delia. No problem. So as far as what to expect, the MOC documents vary depending on the plans, but a good range is usually around 100 to 150 pages. We are looking for detailed descriptions of the what, how, and who process steps in the MOCs. And surveyors should make use of the matrix as it will outline where to find information within the MOC, and to remember that there may be appendices or screenshots embedded within the MOC document. Next slide, please. For support text box language, please keep the comments brief and describe what is missing or what the issue is. You should explain what details were missing and what areas the plan did not address. For the cure, as we mentioned earlier, we do not score down. If a score changes, you should place a comment in the internal notes section. Also, just wanted to note again that HPMS does not accept certain characters, so please be mindful of these characters and write them out instead. For internal notes, if you have a question for the ER, you can add a note in the internal notes section, as the ER should be checking the internal notes during their reviews. And if you do have questions for us at NCQA, please just reach out directly to us instead of adding an internal note. Next slide, please. For scoring, we do want to make sure that we are scoring consistently. For the corporate tools, we want to assign the same score for the organizations with same documentation. Also, if the scores for a plan in the same corporate family differ, please be sure to explain the scoring differences. Next slide, please. Listed on the slide are the available resources that we will have for surveyors. We are updating this information, but once we are finished making changes, you will be notified about where to find the resources. We've also provided a link to the SNP MOC website where you can find the recordings from the SNP plan trainings. That could also be a good resource for you as well. And again, if you have any questions for us, please feel free to reach out to the SNP approval mailbox. Next slide. And we just wanted to say that we're trying our best to make this process as easy as possible for everyone. For the SNPs, we said to make this simple process for the reviewers, and for you as a reviewer, we want to ensure that the SNP is addressing all the requirements for all elements and all factors. Next slide, please. So we've already held our trainings for the SNP plans, and today's training was our first surveyor training. The next surveyor training will be next week on Tuesday, February 5th. The ER training will be on Thursday, February 7th, which is by invitation only. Additionally, we will hold weekly calls for surveyors just as an opportunity to talk through any questions with each other, or if you have any questions for us. These surveyor calls will be every Wednesday from 3 to 4 p.m. Eastern Time, starting on Wednesday, February 21st, and going on until March 14th. And also, we will be sending a link with the training recordings and slides that will be available within 1 week of the trainings. Next slide, please. And lastly, here is our contact information and the link to the SNP Approval MOC website. Again, please feel free to reach out to any of us by phone or email, or to the SNP Approval mailbox if you have any questions or concerns. And next slide. Does anyone have any questions?
While you're collecting your thoughts, I want to thank you again for attending. I know that you hear this information every year, but what we try to do is tailor it towards your responses or lessons learned from last year or during the off-cycle periods, to let you know what's in the works at CMS, and hopefully just some reminders for how to reach out or when to reach out for us. I know that most of you work 9 to 5, and you do some of your reviews in the evening and on weekends. During the SNP season, I may not be available every evening, but I do at least check my email, and if it's something that we can do to promote your continued review or completion of that review, we will look at the question. If it's something simple that we can take a look at, or perhaps if I'm working late, I will take a look and get you a response back. We also try to do that during weekends because, again, the bulk of the work is done by you on the weekends. So we do try to respond to you as soon as we can, whenever we can. So for those things that trend, those Wednesday calls, that's what those are for, just to let you know that your peers are having the same problem. For corporate type reviews, we try not to give you too many. So the let's say your Uniteds, for example, may be broken up into 2 or 3 or 4 surveyors. We want you to be able to talk about those things. So we will let you know which one of your peers has other UHC surveys to review. I thought I heard a question coming. No? That's all I can think of. Would any of the seasoned surveyors like to put a plug in there for anything that we've forgotten as a reminder or a question, or any of the newbies? If you have questions, or if you want to take it offline, that's good too.
This is Deborah White. It's been a while since I did a SNP review, but when I was doing them, I had gotten to the point of being an executive reviewer. But whether you're a newbie or an executive reviewer, when you get those MOCs that are all from one, mother corporate entity, it really is important, at least I've found, and very time-saving, to do a document compare so that you see which parts are identical and which parts differ. Because for the identical parts, review that part that is identical in all the documents and score it, and then you know that would be the same for all the other 19 or however many there are. And that streamlines and makes sufficient your time use, and then you focus on the parts that are different from each other, because even the parts that differ document to document, maybe 2 or 3 of them are the same, and then 4 or 5 more are the same, even though those 2 or 3 different from the 4 or 5. So if you do the document compare, it'll help you manage your time.
Thank you, Deborah. Make sure that you're looking at the target population, though, to see if there should be some differences. And again, they should be subtle. So for the most part, what Deborah's telling you is a time saver. Anyone else have anything to contribute? We do want to be mindful of your time, even if it is like 10 or 15 minutes that we can give back to you.
Sandra, this is Jean again. On the target population, when you're looking at like chronic conditions or comorbidities, they really don't have data from their population yet because they're just starting out. So they might compare it to their overarching data like in another product in their plan or, from national statistics. Is that acceptable?
Okay, so what I want to say is if they are initial, this is the first time, they may be gleaning in or gathering information from other plans in the area. Let's say it's a small, with doctors' practices, if it's just him, a solo op, we call them mom and pop. So I like to liken that description to the plans. Let's say it's just one small plan who's not related to your Uniteds or your Kaisers or Humanas, that they're lone and they don't have any experience, but they have an idea of what's in their area by looking at the general, national statistics. Yeah, that's fine, but they can say, we are just starting off. We believe this is what our target population will look like, and this is the characteristics of plans in our area that they know of. So I hope that answers your question.
Yes, it does. Thank you.
Uh-huh. Okay, know that you do not, if you've attended this training, pardon me, you do not have to come to the February 5th training. We will be sending out early next week. Those of you who have been ERs in the past, unless we've tapped you and said you will not be an ER, please expect to be an ER this time. And if you can't do it, let us know that too, as soon as possible. Team, any closing comments? Linda, Avni, Delia?
I don't have much else to say besides stay warm wherever you are. It's cold where I am. So thank you all for attending.
Okay. If you have suggestions for how we can make this better for you, please, we welcome your feedback on our performance as well. So I will give you back the rest of your day. Thank you again for joining us on this project this year. Diana, if you'll hold on. Yes?
Is Needy still with you?
Oh, I'm sorry. I was supposed to say in the beginning, Needy has moved on to newer and bigger, better things. I forget what big consulting firm she's working for, but know that it is a major one.
Oh, good for her. Okay.
And I miss her dearly. So thank you for opening that wound.
Sorry.
But I can say that I'm very happy with the addition of Avni and Linda joining the team. They have stepped in, and I do have to say that all my worries about Needy not being here and all of her experience were laid to rest because they have stepped in and stepped up. And I want to thank them publicly for their assistance.
We're looking forward to working with them all. Thank you.
Yes, thank you.
Have a good weekend, everyone. Stay warm.
Bye.
Bye.
Bye. Bye-bye.
Bye.
Bye.